Dr. Tadros, glad to meet you for the first time.
Thanks for having me here. I really would be very happy to answer all your questions that you want to ask. So let's see what you have here.
Yeah, absolutely. What I would love to do is if you can kind of show, because this is stuff that most patients, I've gotten to see some of this again doing what I do, but most patients don't get to see this. So can you walk through the journey on what actually takes place from the beginning? I think you even have a puck or...
Yeah, so when patients come in, the first thing I like to do personally, and everybody in the office like to do, is to scan the patient intraorally. We have multiple intraoral scanners in the office from different brands, and we actually have a digital scan on the computer of their current situation in color. So we can move the teeth around, we can show the patient the situation that they currently have, and on the computer mention exactly where we need to fix things. From there, the patient gets a first perspective view in their mouth, but on the big screen, which is really a wow factor. From there, we explain to the patient the treatment plan on model work. We do everything in this office guided. So everything is surgically guided from a single implant to an All-On-X case. Every single All-On-4, All-On-6 is guided. We don't freehand anything in this office.
Why? Tell me that, because I mean, I've worked with some offices that do both. They'll do some freehand and some guided, but you're saying all guided here with this
Everything
team. That shocks me, not because I'd just be curious why.
Okay, so that's a very good question. So no matter how many years of experience you have, a free-handed surgery could be off a few degrees from where I want my exact screw channel of how I can create a prosthesis that can have all the screws coming in exactly in the center of the teeth or exactly in the lingual, which is very important because once the screw come out of the outside of the tooth, that creates a problem for us as a restorative dentist. So it's really nice to work with a very open-minded surgeon like Dr. Salama, who has over 27 plus years of free-handing surgeries, to all of a sudden say, okay, let's do everything guided because it makes sure that everything for the patient is as perfect as it could be. It's basically like if I tell you I can get the implant within 2 or 3% off angle every single time, versus I could be off by 20 degrees if I freehand it, that's a huge difference.
Big difference.
So we just care for accuracy and we have the ability to do it. Not every office has the ability to do it. So a lot of offices will send out to a lab to have a surgical guide done, and that could take time. And sometimes you don't have the time. The patient wants to move forward with the surgery and it might not be feasible. Sometimes it could be an extra expense on the patient. We don't actually, usually charge extra for that part.
Right.
So it's part of our all-inclusive treatment plan price for our patient. And it's really just to trying to get the best quality result for them. We know where the exact depth of each implant is, which is very important for the thickness of our prosthesis, because if we make it too thin, it can break. If we make it too thick, we're gonna remove more bone than we're supposed to. So we actually design the entire implant process of the surgery on the computer, on the patient CBCT, and then we transfer almost 98% with accuracy to the patient. And the way we do that is we 3D print everything. So this is a surgical guide. As you can see here, the holes is exactly where the drills go. This actually gets fitted on top of another part. Everything is super fit. They click into each other. And this whole part sits on the patient bone after we do a flap. And we know the exact direction of the implant angulation and the depth. Once this is completed, we take this part out and then we're able to put the teeth in, which in this case, this is a clear one just to pick up, but we also are able to print them or mill them in actual hard material that the patient can keep for over 6 months. So we usually have our patients in the healing process for 3 months. And then after 3 months, we transfer the patient from a temporary that they have after surgery to another set of temp with perfection. So
PMMAs?
Yes, 2 PMMAs. So the day of surgery, our patient gets 1 PMMA. And then 3 months later, we make another PMMA. This new PMMA mimics the final, but it's much more improved than the surgical one.
How?
So aesthetics could be better. If we have a little cant, if we are within 2 degrees off, we correct everything. We're very particular about these things. So we have a studio, we take a lot of photos. We put a lot of lines, vertical and horizontal lines on the patient face. And we figure out, are our teeth aligned together on both sides? Is it canted? Is it off? And if so, we correct the occlusion and everything. Also, many times, right after surgery, we don't give the patient the same bite after surgery as we do in the final. So right after surgery, the bite is more flat. We don't want the patient to have walls that they're chewing against, like natural teeth. So the teeth are more flat. The bite surface is more flat. That's to put less forces on the implants. Okay, because if the patient is going to start
dispersing the weight and the pressure, so that instead of them being more central, I mean, so now it's more spread out.
Exactly. So natural teeth fit into each other like a machine. On a surgically temp patient after surgery, the teeth are more flat on the bite surfaces. That allows the patient to slide more freely than actually putting a lot of pressure on the patient implants, which could cause failure. So that surgical temp does not actually mimic the same bite as the next temp. The next temp, the patient actually gets a more of a natural bite, where the upper and lower teeth fit much better together and the patient can chew better. So there is an efficiency gained in the second set of temp. From there, if the patient accepts our temp and they like everything about it, we actually, because we're digital, we can copy the temp 100% into final. And most people don't understand, how can we do it 100%? Because we do everything digital, we actually have the temp that we did, digital copy of it. Instead of milling it into a PMMA material, we just send it to another machine and mill it into a zirconia material, which comes out of the solid puck. This is zirconia. Zirconia does come in different strength, different qualities. So we choose the highest quality. We use couple of different brands that we like with different translucencies. So we've tested many different zirconias, and there's few that we like to work with, and all of our patients seems to like these ones. A lot of problems with zirconia is the fact that it could be opaque, and a lot of people don't know how to deal with it. It's a very difficult material to deal with, because if it wasn't milled correctly, or if it goes into the oven to change to the right color, because right now you see it in the white chalky stage, which is called the green stage. It has to go in an oven at almost 1700 degrees or 1500 something degrees for over 8 hours to even 24 hours. And from there, it actually changes to the right color. The problem is the color sometimes is opaque, and a lot of ceramists, when you talk about lab, they will have to blend in some staining and coloring over there, which actually sometimes could break the zirconia. So our zirconia is monolithic, meaning it's one piece. The only thing that we add on is the gum. Our teeth is multi-shaded, built into the zirconia. And a lot of times when we do the add-ons, this is how it looks after we stain just a little bit and add the pink gum. And you can see this side has no staining or anything like that.
Dr. Tadros, if you could pause for a second. Just to give you guys a heads up, all the background noise, Dr. Tadros has been awesome in the fact that he's staying late to do this for us. We have Dr. Salama. We had a great interview. He had patients. We had to get delayed in getting started on this. So it is 7:35 at night. And so again, any unique sounds you hear in the background, that's not Dan dancing or anything like that. Just wanted to give you guys a heads up, and so that you guys cut us a little slack, because we're pretty sensitive on any sounds in the background, but we got to deal with it today. So again, sorry about that, but here we go. So
do you want me to ask them to?
No, it's fine. It's fine. Well, you know, we've now embraced it, and so you know what I mean. So now you've shown us the half and half. What does zirconia break?
When does it break?
Yeah.
Most of the time it breaks on fast cooling. The problem with zirconia is it needs to go in the oven for a few hours and to be colored. And after it's colored, it takes almost 2 hours to cool down. And a lot of ceramists and a lot of labs, they try to do the process a little bit quicker. Instead of waiting the hour and a half or 2 hours, they will wait just 45 minutes and cool it quicker. And that can create internal cracks. And the problem with that, it could break right when I'm delivering it. So
really?
It looks
that
great.
quick?
Yes. It could actually look great when I have it in my hand, but as soon as I screw it in, it cracks all the way through. If it passes the test and it goes into the patient mouth with no cracks, you're good. But a lot of times it can actually crack in shipments if it already has an internal crack that you're not seeing. So one of the best tests that we do is actually hold it against the light and see through and see if there are any internal cracks that we're missing. Another thing, when you design zirconia, there is minimum thickness to it. That's why we plan everything on the computer. You were asking, why do you digitally plan everything and why do you guide everything? We like our zirconia to have a specific minimum thickness vertically and in width, which actually give it strength. And from our research that we have, we found that we have very minimal problems. In fact, since the last 3 years, I've only had one crack. So this is why I wanted to start my lab here at the office, is because we wanted full control over quality and speed. So we can have zirconia done in less than a week from start to end. We can mill it, stain it, and deliver it in less than a week. Some people,
that's fast.
Yeah, but some people do it in 24 hours to 48 hours, which that's when I'm thinking,
cutting corners.
So it's very important. Also, some people, I see, especially in social media, something that's disturbing sometimes, in my opinion, which is over removal of the bone, over reduction of bone.
Oh my gosh.
So, and some of these clinics are very successful. And it's because I know it can be done in a different way, which is more conservative. It kind of breaks my heart sometimes to see it. So Dr. Salama and I actually already published last year or a year and a half ago about the scallop design. Excuse me, sorry.
That's all right.
So the scallop design is, instead of us cutting the bone flat or removing excess bone that we can save, we actually scallop the bone to create the same architect as the tooth margin, which actually reduces bone reduction and also looks more natural. Yeah, I can show you a case on the computer if you want to record it. But this actually is a proof of that concept. So if you want to see this, this is pretty impressive actually. So instead of us doing...
So how many okay, so are you at 8 millimeters, 5 millimeters, 10 millimeters? What is your average? And I know it sounds like I know each one's custom, but how
so
much?
Depending on implant positions and how many Pontics we have and how many cantilever teeth we have, the numbers do change. They can range anywhere between 10 to 14 millimeters.
Okay.
Minimum, I would say 8 to 9. Also, the bite scheme actually change. If we have thinner zirconias, we reduce bite forces. So there's so many factors that most people don't even really realize. And that was my main interest back in school, is actually treating All-On-X patients. I call it All-On-X because we don't go for All-On-4. Minimum All-On-6, if we can fit 8, that's even better. We always over-engineer the process. In case you have 1 failed, 2 failed, you can still keep going. So this is very interesting right here. So this is a scalloped bone right here. And this scalping was actually done by this surgical guide right here, as you can see there. And the scalloping of the bone matches our prefabricated design that we have before surgery. So this fits right on after we place the implants, which the implants are also guided using this guide right here, which all of these guides we created in the office and printed them here. So we make our own guides and everything. So this guide fits on, and the drilling happens for the implant depth and location. Because I know my implant location, I can already prefabricate my temp with the right hole position. And when the implants are placed in the patient mouth and the bone have been already scalloped before that, we place the prosthesis and then I pick it up. Now I have a perfectly scalloped bone. I have the right spaces between the prosthesis and the bone, allowing for the tissue to actually grow into the papilla, which is something extremely hard to do.
That's really difficult.
Yeah. In fact, I'm not sure if Byron mentioned to you. Did he mention Lisa?
that she's almost on her final.
Yeah.
Like she's on her final.
So
set,
yeah. So Lisa's treatment was done scalloped.
Oh really?
His treatment was done with a flat. So husband and wife, two different treatment for two different reasons. She had a lot more teeth that we could salvage the roots and keep them into the bone, allowing for preservation of the bone, versus him, he had a different situation. So it's not, All-On-4 is not a treatment that you just remove bones, same for everybody, make the same teeth and everything. So all of our teeth are also made custom for the patient faces, which is also another interesting thing that we do here.
Yeah,
Yeah.
that's awesome.